Welcome to the debate. We're looking at one of the most high-stakes intersections in pediatric medicine today. It's that precise moment where the clinical mandate to heal collides really head-on with the legal mandate to police. We are talking about pediatric genital exams.
And it is the kind of topic that just makes everyone in the room sort of hold their breath. You know, parents, children, and honestly, a lot of clinicians too. We are discussing a procedure that is, well, technically a routine diagnostic tool, but it carries enough weight to destroy a family if it goes wrong.
The central tension here isn't just about discomfort. It's about a much harder question. When does a necessary medical investigation become a potential source of harm? And conversely, how do clinicians navigate that incredibly fine line between medical necessity, diagnosing a physical ailment, and reasonable suspicion of abuse?
That line it's nowhere near as distinct as we like to pretend it is. You have the imperative to catch emergencies, sure. But on the other side, you have the very real risk that a well-intentioned exam triggers a mandatory reporting process based entirely on subjective interpretation. You're basically deputizing doctors as investigators, and that just changes the doctor-patient relationship on a fundamental level.
But you can't divorce the two. My stance is that the genital exam is a fundamental, non-negotiable aspect of pediatric care for specific symptoms. If a child comes in with dysuria or blood in the urine and you don't look because you're afraid of acting as the state, you are neglecting that patient. You risk missing testicular torsion, infections, foreign bodies. When strict protocols are followed, these exams are safe, objective, and vital.
And I take the skeptic's view on that protection. I would argue that the subjectivity of reasonable suspicion and the high risk of misinterpreting findings, mistaking a skin condition for trauma, for instance, pose significant and often understated risks. I believe the potential for trauma, both medical and legal, requires us to have a much higher threshold for intervention than we currently do.
Let's get into the clinical reality then, because I think it's easy to critique this from the outside and forget why we do these exams in the first place. This isn't a witch hunt. It's routine medical care. If a child presents with symptoms like dysuria, painful urination, frequency, or hematuria, you have to investigate the source.
I don't dispute that there are medical indications. But let's be honest about the frequency. We aren't just talking about trauma cases here. We are talking about routine complaints where an exam is performed and suddenly a family finds itself in an absolute nightmare scenario because of a misinterpretation.
But consider the consequences of not looking. Okay, take the case of a 7-year-old boy presenting with dysuria. If the clinician just assumes it's a urinary tract infection and prescribes antibiotics without a physical exam just to spare the child embarrassment, they are playing a really dangerous game. That boy could have testicular torsion.
Torsion is an acute surgical emergency. No one is arguing against examining a screaming child with an acute scrotum.
But torsion isn't always screaming. It can present as abdominal pain or just vague discomfort. A high-riding tender testicle is a physical finding. You only get that data point by looking and palpating. If you miss that, the boy loses a testicle. That is permanent physical harm caused by a failure to examine.
Granted, for torsion. But let's look at the girls. You have an 8-year-old with dysuria. The vast majority of the time, that is a UTI or a hygiene issue. But the protocol demands a visual exam.
Because it could be a genital abrasion. It could be labial adhesions. It could be a foreign body. You cannot diagnose a foreign body or a structural abnormality just by asking a parent a history question. You have to look. Symptoms like lower abdominal pain or discharge legally and medically require examining the relevant body part. To not do so is practically malpractice.
See, practically malpractice is where you lose me. You're framing this as a binary choice, exam or negligence. But there is a third option here, the false positive. Differentiating accidental versus concerning injuries is notoriously difficult. We are not talking about diagnosing a broken arm where the X-ray tells the truth. We are talking about soft tissue, mucosa.
Soft tissue tells a story, though.
Does it? Or does it tell the story the doctor expects to see? The thing is, there are conditions like lichen sclerosis, eczema, or even just dermatitis from a bubble bath that can visually mimic trauma. They cause redness, they can cause tearing, they can cause bleeding.
which is exactly why you need the exam to distinguish them.
But if the clinician isn't a specialist, if they are a generalist in an urgent care seeing a red rash, they might flag it as suspicious, and because of mandatory reporting laws, that flag doesn't just stay in the medical file. It goes straight to the state. Reasonable suspicion does not require proof. So routine care can spiral into an investigation based on a rash that turns out to be eczema. That is a massive risk to ask a family to accept for a symptom like urinary frequency.
I think you're conflating the exam with the report. The exam is the tool used to distinguish the mimic from the abuse. Without the exam, you're just operating on blind suspicion. If a child has lichen sclerosis, they need treatment for that. You can't treat it if you don't diagnose it, and you can't diagnose it if you don't look.
But the risk of that false positive report is inherent to the exam process in our current legal climate.
Okay, let's dig into that risk then. The threshold for reporting is reasonable suspicion,
Which is just about the most slippery phrase in medicine.
It's meant to be an objective standard based on facts. It involves specific triggers, injuries that are inconsistent with the history provided, repeated unexplained trauma, or a significant delay in seeking care. This isn't about a doctor having a hunch. It's about a mismatch between the story and the physical evidence.
Objective standard. Come on. The guidelines explicitly list caregiver behavior as a flag for suspicion. They tell clinicians to look out for a caregiver who appears fearful, defensive, or unusually angry.
Well, context matters. If a parent is acting erratically, it's a data point.
But context is in the eye of the beholder. Just pause and think about the human element here. You're a parent. You're in an ER. Maybe it's 2 a.m. A doctor says they need to examine your child's genitals. You might naturally feel defensive. You might be fearful because of your own past trauma, or because you belong to a community that has historically been mistreated by the medical system.
That is a fair concern, but clinicians are trained to differentiate.
As a red flag that contributes to reasonable suspicion, then we have a serious problem. The standard penalizes parents for being protective. The question, is there anything about the caregiver's behavior that raises concern, introduces a massive amount of subjectivity into what should be a clinical decision. A defensive father could be a loving protector or a perpetrator, and asking a general pediatrician to make that psychological profile in a 15-minute visit is, well, it's absurd.
I think you're stripping the clinician of their judgment. We aren't robots checking a box that says angry dad equals abuser. We are looking for consistency. Take the developmental mismatch. If a non-mobile infant, a baby who cannot crawl or walk, has bruising on the genitals or buttocks, that is an objective red flag. That isn't about the parent's attitude. It's about physics and biology. A baby cannot bruise themselves there.
A non-mobile infant is a clear-cut case, and I'll give you that. If a baby can't move and has bruises, you report. No argument there.
But what about the toddler? What about the straddle injury? Straddle injuries are common, and we know what they look like.
We think we know what they look like, but distinguishing a clear accidental injury, like falling on a playground structure, from a concerning injury often relies on the clinician's judgment of the story's plausibility. And plausibility is subjective. If a doctor has an unconscious bias against a certain demographic of parents, they might find a story implausible that they would accept without question from another parent.
It is fallible because humans are fallible. I get that. But the alternative is to ignore the potential for neglect. Reporting is required when there is a concern based on facts, even if they aren't sure. The system is designed to err on the side of protecting the child.
But erring on the side of protection for the child often means destroying the stability of the home. Once that call is made, that train has left the station. Reasonable suspicion does not mean proof or certainty. It means abuse could be happening. That low bar, combined with the subjective interpretation of parental behavior, creates a dragnet that catches innocent families.
I'm not convinced by that line of reasoning, because it ignores the rigorous protections that are put in place during the exam to prevent these misunderstandings. We aren't just winging it. There are protocols.
Protocols are only as good as the people following them.
It's transparent. Second, there is consent or assent from the child. And third, and this is most important, the mandatory presence of a trained chaperone.
The chaperone is a shield for the clinician, primarily.
No, it protects everyone. Policies require a chaperone for any genital exam, and this person cannot be a family member. It has to be a trained staff member. This ensures there's a witness to the professionalism of the exam, and it diffuses that one-on-one power dynamic. If a doctor is acting inappropriately, or if a parent misinterprets a medical maneuver, there is a neutral third party in the room.
That's the theory, but let's talk about assent. We talk about informed consent of the parent, but for the child, it's assent. The clinician explains in age-appropriate language and asks permission. Is it okay if I take a quick look? That sounds nice on paper, but in a doctor's office, there's an immense power imbalance. If an 8-year-old is scared or embarrassed, do they really feel free to say no, or do they comply because an adult authority figure is asking?
And that is why trauma-informed care is the standard. It's not just about getting a yes, it's about giving the child control. The clinician uses a running commentary explaining every single move before it happens. They tell the child, you can tell me to pause anytime. They use drapes to limit exposure. These are not just niceties. They are clinical standards designed to preserve dignity.
And what if the child says no, or the parent says no? This is where the protocol really reveals its teeth.
If a competent caregiver refuses a non-emergency exam, the clinician documents it. They don't force it.
Unless
Unless it is life-threatening or there is clear neglect.
Right. And neglect is a very wide net. The definition includes failure to heed obvious signs of serious illness. So, if a parent says, I don't want you examining my daughter there because it's against our cultural modesty norms, and the doctor suspects a serious infection, that refusal itself becomes evidence of neglect. That places the doctor in a position of immense power over the parent's rights. It turns consent into consent, or I call CPS.
But we have to prioritize the child's physical safety. If a child has a necrotic bowel or a twisted testicle, parental modesty norms cannot override the child's right to live and be free from pain. The criteria for medical neglect are specific: imminent risk of harm and a clear net benefit versus risk. If a parent refuses a visual exam that could save a testicle, a reasonable caregiver would be expected to choose the exam. That isn't tyranny, that's protecting a vulnerable minor who can't advocate for themselves.
I accept that for life-threatening cases. If a kid is dying, you do what you have to do. But we're applying this medical neglect leverage to gray areas, to rashes, to discharge, to dysuria that might just be a UTI. The coercion is subtle but very real. You're asking parents to trust a system that holds a nuclear weapon over their heads.
We are asking them to trust that we are trying to solve a medical problem. You mentioned earlier that the exam distinguishes mimics from abuse. I want to circle back to that because that is the strongest argument for the exam.
Or the strongest argument against it, depending on the doctor's skill level.
Visual exams clarify ambiguity. That is their whole purpose. You distinguish between abuse and medical conditions like yeast infections, dermatitis, or urethral irritation. Without the exam, these treatable conditions are missed. You can't treat vulvovaginitis if you don't know it's there.
That assumes the doctor knows what they are looking at. Let's talk about error rates. We have medical mimics: lichen sclerosis, eczema, urethral prolapse. These conditions can look exactly like trauma to the untrained eye. They can cause bleeding, redness, even tearing. If a general pediatrician isn't a specialist in urology or gynecology, they might misinterpret a medical rash as a sign of sexual abuse.
And that is why the protocol includes referral. If you are unsure, you call a specialist.
But the referral often happens after the suspicion is logged. If a doctor sees a hymenal tear, or what they think is a tear, but is actually a congenital notch or a scrape from scratching eczema, the damage is done. The criteria for reporting include injuries inconsistent with history. So if I say she hasn't been injured and the doctor sees a mark caused by lichen sclerosis, my history is now labeled inconsistent with findings, and that triggers the report. The train leaves the station before the specialist ever walks in the room.
That's a valid fear, but you are assuming the worst of the documentation process. Clinicians are explicitly trained to document objective findings to prevent exactly this scenario. They don't write abuse, they write mild erythema. They describe the size, shape, and color.
Mild erythema is one thing, but suspicious bruising is another.
But they shouldn't be writing suspicious. They should be writing 2-centimeter purple ecchymosis on the left labia majora. And for complex cases, like complex labial adhesions or structural abnormalities, they involve specialists. They call in urology or gynecology. We have child protection teams. These aren't just police. They are medical experts who know how to differentiate these mimics. The system has filters built in to catch those false positives.
The system attempts to filter them out, but you know the adage, err on the side of safety. In practice, that often means reporting when in doubt. And for a family, erring on the side of safety can mean a CPS investigation, interviews with neighbors, strip searching the other children. That process can traumatize the child far more than the original medical issue ever would have.
I think we have to look at the alternative. If we raise the threshold too high because we are afraid of false positives, who falls through the cracks? We miss the child with STIs. We miss the child with repeated unexplained trauma. We miss the signs of sexual contact in a prepubertal child. These are things that must be caught. The exam is the only window we have into that reality. If we close that window because we are afraid of offending parents, we are abandoning children to their abusers.
I agree that the window needs to exist. My concern is that the curtains are often pulled back too aggressively, and once they are open, the documentation becomes permanent.
So let's talk about that documentation, because I think this is where the protection for the family actually lives. You mentioned the risk of a doctor writing a judgmental note, but the standard of care is the opposite.
Do not use judgmental language. I know the rule.
It's more than a rule, it's a shield. Descriptive language protects the family. Right testicle high writing, tender to palpation, or child cooperative but anxious. It also demands quoting the parties directly, record exact statements. This factual, neutral documentation is what saves a parent from a false accusation later. If the notes say parent explained injury was from bicycle fall, and the exam shows superficial abrasion consistent with straddle injury, the case is closed. The documentation proves the innocence.
Ideally, yes. But it also records the refusal. It records the anxiety. Caregiver appears fearful. That subjective note becomes a permanent part of the record. And I just worry that we are asking parents to trust a system that holds all the cards. You say documentation protects them, but documentation is written by the person with all the power.
We are asking them to trust a system that is designed to heal. The goal isn't to catch parents, it's to treat children. When a clinician explains, I need to check for infection, they are trying to solve the dysuria.
And I suppose that brings us to the crux of it. It's about communication. If you want to avoid trauma, you have to talk to the family, not at them.
Absolutely. Sensitive exams require simple, transparent, and medically focused explanations. You can't just barge in and say drop them. You have to explain the why.
And I would add, they require deep empathy. There is a framework called WITH: wonder, investigate, treat, hope. It shifts the question from what is wrong with this patient to what has happened to this patient.
I love that framework. It really encapsulates the advocate's position too. By wondering and investigating, by doing the exam, we can treat.
As long as the investigation itself doesn't become the trauma. You have to understand that for many families, the investigation is the trauma.
Indeed. So let's try to land this plane. Where does the clinical imperative stand? For me, the genital exam, while undeniably sensitive, is a vital diagnostic tool. You cannot diagnose testicular torsion or severe infection over the phone. You cannot spot a hymal foreign body by guessing. When protocols regarding chaperones, objective documentation, and clear communication are followed, this exam ensures children receive necessary treatment for physical pain and, yes, protects them from genuine neglect. To avoid it out of fear is to fail the patient.
And I will maintain that, while necessary in emergencies, the weight of these exams requires extreme caution. The overlap between medical mimics like eczema and lichen sclerosis and signs of trauma is a minefield. Combined with mandatory reporting laws based on suspicion rather than proof, the risk of false positives is real. Clinicians must prioritize informed consent, true uncoerced consent, and deep empathy. We have to ensure that in our rush to cure or protect, we don't inadvertently traumatize the very families we are trying to help.
Ultimately, both sides agree that the goal is the child's safety.
We do. We just differ on whether the primary risk is missing a medical diagnosis or inadvertently harming a family through investigation.
And that is a tension that every clinician and every parent has to navigate. There is always more to explore, particularly regarding the specific legal variances in different regions, but the principles of clear communication and patient safety remain universal.
Absolutely. It's a conversation that needs to continue.
Thank you for joining us for The Debate.
Thank you.